The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello to all you TMD warriors. I'm Tony Urbanek, and we are gathered here today for the next episode of TMD Demystified. Today, I've chosen the topic to carry on with the previous concepts that I've started with the thought of the scandal, the TMD, and the scandal of misdiagnosis. Misdiagnosis of TMD. And today we're going to concentrate on the misdiagnosis of migraine headaches. The first, part one, this is part three. Part two had to do, focused on Meniere's disease. And today we're going to talk about migraine headaches. I did briefly mention migraine headaches when I opened it up with part one, poking the bear. And after dealing with this issue for years and years, I can see why there is so much confusion between bad headaches associated with TMD and bad headaches associated with migraines. I am not here to tell you that treating the temporomandibular joint by unloading the joint and decreasing the inflammation decreases or takes away or diminishes or ameliorates all headaches that have been diagnosed as migraine headaches. But I am here to say, and we can prove it in several different ways, that patients, many patients, like many thousands of patients here in my practice and millions of patients throughout the United States and the developed world, as we know it, have been diagnosed with migraine headaches and treated for migraine headaches where the original culprit cause is inflammation within the temporomandibular joint. That is what I'm trying to say and what we're going to talk about. So, and I can understand why there's so much confusion about this, because first of all, those who study and write upon and do papers on migraine headaches, the first thing that they say is, we do not know what causes migraine headaches. And they have all kinds of classifications for migraines and all kinds of theories about migraines. But today I'm just going to talk about migraines as they are currently understood a little bit. I certainly can't cover the whole waterfront. It is a huge topic. There is a lot written, scientifically written, about migraine headaches, as is there a lot written scientifically about TMD. But let's see if I can keep going in the same direction and keep this straight. So first of all, I just pulled up a review of migraine headaches off of Wikipedia. Now, I don't claim Wikipedia is the end all and know all about discussing migraine headaches, so don't accuse me of that. But it is a good compilation of the general understanding and what is out there, and has been reviewed to some extent of peer reviewing, not ideal, but some extent of peer reviewing. And so I'll quote from certain aspects of migraine as it appears on Wikipedia. And then I will talk about bad headaches as they're associated with TMD, which we know in our practice and our network providers who treat TMD using the Urbanek device and protocol, that they diminish bad headaches, frequently called migraines by doctors and others. So let's just start out with migraine itself. I think it's derived from ultimately the Greek, and is defined as a primary headache disorder characterized by recurrent headaches that are moderately to severe. Typically, episodes affect one side of the head, pulsating in nature, and last from a few hours to 3 days. Associated with nausea, vomiting, and sensitivity to light and smell. Pain is generally made worse by physical examination, although regular exercise may have prophylactic effects. Prevalence: up to 1/3 of people affected have aura, typically a short period of visual disturbances. We'll focus on that in a little bit. Short period of visual disturbance that signals that the headache will soon occur. A prodromal of aura. Occasionally, aura can occur with little or no headache following, but not everyone has this symptom. So basically, they claim that, what I've said multiple times, that a true migraine is differentiated from any old other kind of bad headache classification, true or false, correct or incorrect, classified specifically as having an aura. A migraine is usually associated with having some kind of aura, meaning usually visual disturbances of various kinds, a limitation of the virtual spread of the eye, or decrease in light, spots or lines before the eyes, any kinds of unusual visual disturbances can occur. The underlying mechanisms are not known. They are, however, believed to involve the nerves and the blood vessels of the brain. Now, that's the general consensus placed on Wikipedia what a migraine is. The burden of the disease, prevalence study of 2010, migraine was ranked as the third most prevalent disorder in the world. Third most prevalent. So bad headaches classified as migraines, as they say in the South, migraines, were the third most prevalent disorder in the world. So it's a very common problem, as we know. As I've stated before in my evaluation, in our practice and others, in other studies, 45% of females have TMD headaches, TMD symptoms, may not all have headaches. I won't list off the symptoms again, but headache is the most common symptom associated with TMD, and neck pain is the second most common symptom associated with TMD. So migraines are poorly understood, generally recognized having to do with the nerves and blood vessels of the brain. That is why migraines frequently are called trigeminal vascular headaches, is a general description, classification, trigeminal vascular or vascular trigeminal, whichever one you want to put first, having to do with the trigeminal nerve and the vascular system. All right, that's a general description of migraine headaches. Now, the issue is, in our culture of medicine, what is the general consensus of where the treatment options lead? If you have the last episode, we talked about the differential diagnosis of TMD. And in that differential diagnosis, of course, on the symptom list of the differential diagnosis that you're looking at, migraine is number one. So it stands to reason that you would want to be able to distinguish between the thing called migraine headaches and the TMD headaches. Well, the people, as it turns out, who study migraine headaches either have no knowledge of TMD causing bad headaches, or they don't confront or discuss or study the possibility that inflammation within the temporomandibular joint can cause bad headaches. Because in all of the papers that I've reviewed, this Wikipedia just being the most recent and just one of them, I've reviewed several very scientific articles on migraine headaches, all of which say we don't understand what causes migraine headaches. None of those studies and papers bring out the fact that inflammation within the temporomandibular joint may be one of the causes of migraine headaches, bad headaches. Some of the other causes that are discussed can be genetics. They concede that it is seen, although they do not have a specific gene that they've identified being able to cause migraines. They concede that it does run in families, both male and both male and female, but it runs in families. So it'd be more, in my mind, more appropriate to call it familial rather than genetic, but it does run in families, like we know TMD runs in families, basically mother and daughter all the time. You know, mom comes in with the problem, and next thing you know, she brings daughter in, and daughter comes in with TMD, and the next thing you know, she brings mom in. Constantly happens all the time. Causes, dietary aspects are claimed to cause migraines. Environmental aspects that trigger migraines. Studies confirm environmental factors. Indoor and outdoor air quality being one of them. So, and then the biggest one that is discussed is anxiety. There's a, see if I can find it. In this article, tentative evidence supports the use of, as far as therapy goes, tentative evidence supports the use of stress reduction techniques such as cognitive behavioral therapy, biofeedback, and relaxation techniques, and regular physical exercise. All of which we know physical exercise can decrease bruxing, but all of the above can decrease bruxing. Cognitive behavioral therapy, biofeedback, and relaxation techniques can decrease bruxing to a significant degree. So you see where I'm headed with this. If you decrease bruxing, and the decrease in bruxing can decrease forces on the joint, which decreases inflammation, you are possible and likely to decrease the inflammation in the joint, which then decreases the symptoms. So you can see why my statement, I can see why the people who write upon migraines are confused and can be confused with its relationship to inflammation within the joint, and inflammation being in the joint being the primary mover and common denominator of TMD. So therefore, there is a huge, very frequent misdiagnosis of migraines. Now, this can go in a few different directions. First thing that came to my mind was, I think I mentioned recently in the past 4 months, I had the opportunity to lecture on TMD to the family practice group at Meharry Medical College. These were practicing physicians. There were about 20 of them in the room who were in their family practice group. And I lectured them on the relationship of TMD and the misdiagnosis that may be going on. And number one, they all agreed. They all shook their head positively and said, basically, oh my God, every time I get somebody in with bad headaches, the first thing I do is I order an MRI looking for brain tumors. Well, first thing they should do is consider the differential diagnosis of bad headaches. And on that list should be near the top, certainly not brain tumors, because they happen very infrequently, extremely infrequently, as the cause for bad headaches, but inflammation in the joint. When I explained that to them, they were more than interested in differentiating bad headaches, quote, migraines, from TMD. But the amount of the number of doctors, PCPs, walk-in clinics, nurse practitioners, physician's assistants, neurologists, ENTs, who misdiagnose bad headaches as migraines rather than TMD is profound. I don't know the grand numbers, but I can tell you in Middle Tennessee, it's in the thousands, or if not hundreds of thousands. In Tennessee, it's definitely in the hundreds of thousands, and throughout the United States, it's in the millions per year. So that's why I titled this presentation, The Scandal, the TMD scandal, misdiagnosis of migraine headaches. It is a scandal. I'm trying to help. I'm trying to figure it out for others and then educate our medical compatriots, colleagues. And in Middle Tennessee, we're doing a pretty good job. The date is July 5th today. And today being the next day after the holiday, I just received the month report of new patient providers that we have into the practice, referring patients into the practice. That is, new doctor or practices who refer TMD patients into the practice. And last month we had 12 new doctor practice providers who are new to sending TMD patients into our practice. And 3 of them were PCPs, and one of them was an endodontist, as I recall. We had physical therapists, and the rest of them were various kinds of dentists. But point is that's a lot of new doctors referring patients into a single practice. But number 2, we are making good strides into educating our medical colleagues as to differentiating bad headaches between migraine headaches and TMD, which is part of the marketing effort and proprietary marketing program that we use. But the point is that this is not at all common through other parts of the United States, which is why I'm doing this podcast in this episode. All right, I hope I'm not being too obtuse about the whole thing and trying to be as direct as I can. So this is the reason that that our medical colleagues don't acknowledge TMD, because they're not aware. They're just not aware that inflammation within the joint and the thing we call TMD can cause bad headaches. So any bad headaches to a medical doctor is a migraine, and then they classify them and they figure them out, and they have theories about what causes migraine headaches, but not once, not ever on any of the papers that I read, and certainly not on this little review out of Wikipedia, even mention the fact that TMJ inflammation may cause bad headaches and can be confused with migraines. So that's a scandal. If they constantly had a huge number, hundreds of thousands, if not millions of people misdiagnosed between heart disease and diabetes, and if they had diabetes and it was diagnosed as heart disease, that would be a scandal. And it's therefore a scandal, can be classified as a scandal. Now, getting back to the main differential between, and a migraine, as we know it, defined as and classified in the medical literature, is auras of various kinds that precede as a prodrome the actual pain that occurs. So I mentioned this before in one of my other episodes, but it's here. I want to talk about it again, because we did a study, independent study. I paid for and requested Middle Tennessee, a group out of Middle Tennessee, to take our 3,000 plus patients and do a study on how well the device and protocol, which unloads the temporomandibular joint, affects each and every one of the symptoms. And we won't go through the whole paper. This is just the table of the results, which were in the white paper. But on this table near the bottom is a column and a row called visual disturbances. And as I didn't write the questions, I didn't set up the study. It was independently done. I just commissioned it. But when I talked to the doctor, the PhD, who actually did the study analytically, statistically, and gathered the data, I mentioned to him, when we're talking about headaches, that the main difference between a TMD headache and a migraine headache was visual disturbances. I said, you probably just need to ignore asking questions about visual disturbances on the study, because it won't apply to TMD. Well, I don't know whether he didn't hear me or whether he intentionally heard me and decided he wanted to find out for himself, but he added visual disturbances as one of the questions to our patients, some of those 3,000 patients that we saw, as to the effect on their visual disturbances. And the results were eye-opening to me. And basically, I quote you the statistical analysis, and I will in a moment, but it showed me that a significant number of our patients not only had visual disturbances associated with their headaches and other symptoms, but their visual disturbances decreased also as their headaches decreased and the other symptoms decreased when you unloaded the joint and diminished the inflammation, and the symptoms diminished and went away. So in this case, I'm going to quote the study itself a little bit. Not that it's probably not the right way to do this, but I'll just quote it. There were of the, I think 258 people that were randomly selected from the 3,000 people that we studied. There were 66 of those patients who noted that they had visual disturbances along with their other symptoms, because the symptom list goes from headache to jaw joint pain, limited opening, jaw popping, bloody, going down the list, ear pain, dizziness, vertigo, shoulder pain. But near the bottom, actually second to the last, was visual disturbances. There were 66 who claimed they had visual disturbances. Of those 66, the study was divided into patients who had previous treatment for TMJ or TMD problems, that they knew they had the diagnosis and had previous treatment of any kind for TMD, and those that had not previously had any treatment. So there were 66 in the series that claimed they had visual disturbances, and there were 37 who had visual disturbances but had no previous treatment. Of those that had previous treatment for TMD, basically there was a 61% decrease in their symptoms, a 61 decrease in their symptoms, which was statistically relevant to 0.01. And of those who did not have previous treatment, it was statistically significant to 0.01, with 82% decrease in their visual disturbances. So depending on what portion, either previous treatment or no previous treatment, there was in both classifications, there was significant decrease in their visual disturbances to 0.001, which is highly significant analysis, statistical analysis, with 61% decrease in symptoms of those that had previous TMD treatment and 82% that had not had any previous treatment for TMD. That opened my eyes. I was really surprised by that. So the point is that number one, patients who are diagnosed with TMD and have many of the other symptoms associated with TMD also have visual disturbances, and those visual disturbances can and will decrease significantly by unloading the temporomandibular joint over a period of time using a protocol and a device that separates posterior teeth and unloads the joint long enough to allow the inflammation to diminish. That is a profound study, and it's a profound analysis, and it is factual, and it opens up a lot of other questions. And it definitely opens up a lot of thought-provoking questions regarding how in the heck we're going to educate our medical colleagues to the fact that they're misdiagnosing millions of patients, primarily women, who complain and bitterly complain to them about frequent and recurring headaches, which are really not migraine headaches. A good portion of them are coming from the TMD, which is easily diagnosed by the history and a little physical examination, pushing on the joint, and if the joint hurts, the joint's inflamed. If the joint's inflamed, they have TMD. It isn't even recognized, except here in Middle Tennessee, by almost anybody in the literature or otherwise. So in summary, I guess all I'm trying to say is there's a lot of work to do here, and we have a growing network of doctors who use our device and use our protocol and get the same kind of results in their practices throughout the United States. We now have about 20 or so. Some of them are growing rapidly in using the device. Some of them are growing, but not so rapidly, because it all has to do with how you market the device and protocol, which is nothing more than making other doctors aware. And we have that process nailed down, how to do that. A little proprietary program, which is discussed elsewhere in these episodes. But I encourage you, if you're listening to this, I encourage you to strongly consider the effect that you will have on your community and on the ability of patients and eventually the medical doctors in your community to correctly diagnose bad headaches and be able to distinguish between a true migraine, if there is something as such as a true migraine. I do not claim all bad headaches come from the temporomandibular joint. I do claim, and now can prove statistically, that migraines are being misdiagnosed all the time. And that's a different study. Is what percentage are being misdiagnosed? Well, that's a whole different study, not a hard study to do. Actually, a pretty straightforward study to do. What percentage on average? That would be maybe for some other time or from some other person, an easy study. That's a study that needs to be done in dental school. I mean, some even a senior dental student can pull that off without any difficulty at all if he has an interest. And I would encourage anybody listening to do that. So I've spoken my mind for today. I hope I've made the point. If you are interested in pursuing these methods and using the organic device and protocol in your practice to actually solve the TMD problem, we have the solution. And now we're trying to figure out how to bring it to a much wider area, bring on other doctors in the network, and educate and enlighten our medical colleagues so that they properly diagnose TMD, to send it to the proper people who can have the solution, which are dental types. You have to have a basic type of dental knowledge to actually use the device and protocol in the proper way. I encourage you to contact us and talk to us and tell us what your interests are and why. I encourage you to join the network. We can give you more information if you want to talk to me at Tony@tmjservices.net. Our Director of Marketing and Education is Naomi at tmjservices.net. And of course, our website is www.tmjservices.net. For today, I appreciate your interest and your awareness and listening to the end of my presentation. I look forward to the next time we can speak, which will be in about another week. And I'll pick another topic on the issue of demystifying TMD and making it as simple as possible for you and all of our other medical and dental colleagues.